Hi, everybody. It's Dr. Tenenbaum, Dr. Myckatyn here. Today, we wanted to talk to you about breast reconstruction. October is Breast Cancer Awareness Month, and I think the awareness of breast cancer is definitely out there, but what some people maybe are not as aware of are all their different reconstructive options. And so today, we're going to focus on one particular type of breast reconstruction, which is breast reconstruction with breast implants and placement of those implants in front of the muscle, or pre-pec, which has gained in popularity pretty significantly over the past couple of years.
Yeah, so the evolution of breast implant reconstruction, we used to put the breast implants underneath the chest muscle, which we called postpectoral. And typically we would have to use a tissue expander to stretch that out because there wasn't enough skin to sort of wrap around the implant. But then there have been a couple things that have developed here over the last several years that have really revolutionized this. One of those is nipple sparing mastectomy. So more and more now we can keep patients' nipples, meaning there's more skin. I think when we're able to do so, the aesthetic results are better. And then the other really big one is the use of products to help support the implant. The broad definition or term is called an acellular dermal matrix. And so when you hear patients
or ADM.
ADM, yeah. And when you hear patients or us doctors talk about that, you'll hear products like Alloderm or Corteva or Flex HD or Surgimen or several other ones. And essentially, these are the materials that are wrapped around the implant to provide some form of soft tissue support. So what happened was we would still put the tissue expander or implant underneath the chest muscle, but then we could also expand that pocket by using the support structure underneath this ADM.
As a sling. A lot of people hear that term ADM sling.
Yeah. And then, some people got the bright idea, why don't we just put these implants over top of the muscle and support the entire implant or tissue expander with this sling. And, so there's a couple things. We want to make sure that the soft tissues over top of it are nice and healthy. We want to make sure that, patients are aware, we're doing this, but there's a lot of advantages. A lot of patients have less pain. More often we can get implants in immediately, not always, but more often. And then there's also this thing called animation deformity. So before, if a woman was to flex her chest muscle, it would mean that the implant would bounce around or move around. By putting the implant above the muscle, when she contracts her muscle, the implant doesn't jostle around as much. And so we've been able to limit or even remove, in many cases, this thing called animation deformity. So that's been really revolutionary for us. So people have less pain, their implants don't move around as much, and I think in general they're pleased with those outcomes. So does anybody have any questions?
Well, we have a couple questions from people who sent us messages on Facebook. And so one question is, if you have already had reconstruction after mastectomy and your implants are under your muscle, can they be changed to over the muscle? So that's a great question. And the short answer is usually yes. So especially, and both of us have done this quite a bit, where we transition patients from a dual plane or completely, and dual plane means what Dr. Myckatyn just described, where it's partially covered by muscle on the superior aspect and then the ADM sling below, or complete submuscular, transition them to pre-pec or in front of the muscle with the ADM support. And usually patients will be a candidate for this, but they have to be evaluated, obviously, to see. And normally when we're doing this, it's for women who often complain of a pretty significant animation deformity, as well as pain and discomfort. And for the patients that we have transitioned, I will say for the most part, it's been pretty successful. Most women do feel more comfortable. If they're having those issues with their implant behind the muscle, when we put them in front of the muscle, they do feel better generally. We'll often combine that with fat grafting to help improve that soft tissue coverage between the skin and the implant. Let's see. Do you have to be under a certain BMI in order to have your implants over the muscle? So that's a good question. So I would say for any of these breast reconstruction procedures, BMI is important when we talk about a couple things. Number one, your risk, and number two, your aesthetic outcome. So having a more normal BMI is going to be ideal for both of those things. Typically, women who have a more normal BMI and a more average size breast is going to have the best aesthetic outcome. Women who are very heavy or a higher BMI with very large breasts, it's often more challenging to get as pretty of a reconstruction, especially with implants, but not impossible. But just in terms of kind of setting your expectations where they should be, that's important. We also know that women who have a higher BMI above 30, and then the higher it goes, your risk of things like infection and then ultimately losing your implant due to an infection does go up. So it's not to say that you can't have the reconstruction necessarily, but your risk does go up, and your plastic surgeon can kind of talk you through those risks and the trade-offs.
Yeah. So another thing you may wonder is, so what are the downsides, of doing prepectoral? So there's a lot of upsides. We sort of talked about them, reducing or eliminating this animation deformity. A lot of people will have less pain as well. So those are definitely upsides. Downsides. So and Dr. Tenenbaum talked about this a little bit, and that can be sometimes the upper pole of the breast can have more ripples. Sometimes it loses a little bit of that slope or contour, although not always, honestly. I don't think we necessarily always see that happen, but there's probably a little bit more tendency for that to happen. And
I think it's important to know, though, just on that note, so the visibility of the implant in the upper pole, in general, you're still going to have some of that even if it's behind your muscle. So it's not an either or. I think it's more of a scale, and often you may not even be able to tell the difference in terms of how something looks in front of the muscle versus behind the muscle. But that theoretically might be a little bit more visible pre-pec versus behind the muscle. But that's not to say that if you have your implant behind your muscle that you won't have any visibility to the upper pole of the breast implant, because often you will.
Yeah, so that can manifest either by having a more harsh contour in the upper pole, or more ripples in the upper pole. Again, not necessarily so. And there's ways to sort of try to get around that and make that less so. People may choose a shaped implant. People can have fat transfers or lipofilling or fat grafting, or the implant, the gel in the implant can be made more cohesive or firmer, so that you'll just get fewer ripples just based on the type of implant that's selected, or even just the size of the implant versus the size of the pocket that you're putting it in. So these are all different factors that you can look at doing.
So to piggyback on that a little bit as well, I think that the types of implants that are now available compared to even a few years ago has really helped catapult this technique even higher. I spoke about some of the types of implants when we talked about breast augmentation on Facebook, but just to reiterate, cohesive gel implants, we have a few options now, and there are some more cohesive but still round, smooth implants that don't ripple nearly as much as the softer silicone implants used to, and certainly the saline implants, which I think are one of the biggest offenders. But they still feel really soft. Some of the shaped implants that are available are more cohesive gel, but they can feel quite firm. And then also they are all textured, which a lot of surgeons and patients are using less of. So these newer, more cohesive, smooth, round implants have really made these pre-pec reconstructions, I think, look significantly better than they would have with the older style implants.
Yeah, and one thing that sometimes comes up is people say, well, if it's under the muscle, does that mean that it's not maybe as well supported? And I'd actually argue the opposite. So I think one of the issues is when you put an implant underneath the muscle's contracting and it's pushing that implant down essentially all the time. Whereas, so the muscle isn't providing support. The muscle is providing coverage. And so, because the implant is below the muscle being pushed down. And so the muscle never lifts the implant up. And so, you can argue, I think,
unless it's complete muscle coverage.
Yeah, which is pretty unusual.
Which is pretty old-fashioned, I would say. Yeah. That's a very old-fashioned technique that not a lot of modern breast reconstruction surgeons really use. But if we see a patient who had reconstruction a long time ago and they do have total muscle coverage, that's when you do see the implants almost too high.
Yeah, no, exactly. And so if you use the alloderm, it's the alloderm that's actually supporting the implant. And that's the case whether you do this biplanar, so it's partially under the muscle, partially under the ADM, or if it's completely under the ADM. But if the muscle is no longer on top pushing down, then I believe that implant will actually stay there a little better because there's not this sort of constant force pushing it down. So the reality is that these pre-pectoral reconstructions haven't been around that long. It's probably only been the last several years that they've become more common. And so we don't know kind of how they're going to look 10, 15 years from now because nobody's really, or very few people have had them from that long ago. But we suspect that these implants will also be able to hold their position better for longer as well.
Yeah, I mean, I would say personally in my practice, I've transitioned to almost 100% pre-pec. At this point, it's pretty unusual for me to feel I have a compelling reason not to anymore unless there's an unusual circumstance. But I did want to say one thing that a patient asked me today about detecting cancer recurrence. And so if you have a breast cancer and it's removed from the breast tissue, and now you have the skin of the breast next to the muscle and then an implant behind the muscle, if you were to get a recurrence, say, on that muscle, you're going to feel it very easily through the skin. So if there's an implant in between, does that interfere with your ability to detect that recurrence? So theoretically, the answer would be yes, except that two things come to mind. The first is that it seems, and we're not cancer doctors, keep that in mind, we're just the reconstructive surgeons, but it seems to me like when you find a recurrence, it's often either in the axilla or it's in the skin. It doesn't seem to typically be in the pectoralis muscle. So that's the first thing. The second thing is we've been doing, as reconstructive breast surgeons, we've been doing tram flaps and deep flaps, et cetera, autologous reconstruction in front of muscles for decades. We never put a deep flap or a tram flap behind a pec muscle. That's just not something that's done. And so that concern really hasn't borne out in the autologous reconstruction population. So I would assume that although it's a theoretical thought process that goes on potentially with your breast surgeon, I don't think that is really much different than doing a deep flap in front of the pec muscle, which happens in Terry's practice. That happens weekly. So.
What does?
Deep flaps.
Yeah. So that would be another thing. And then the other truth is these days when people have silicone implants, the FDA is recommending, not that everybody always gets them, but the FDA is recommending that at least every few years, an MRI is done to look at the integrity of the implant to make sure there's no leaks or anything. And so the reality is when this imaging is being done, it's an opportunity to at least have a look around and see kind of what's going on the chest wall to make sure that there's nothing unusual going on. And the reality is whenever we're doing surgery on the chest and somebody who's had breast cancer, any tissue that's being removed is always sent to the pathology lab to look at to make sure that there's no issues going on. So there's a lot of screening unofficially that goes on when we are following our patients as well after breast reconstruction.
Do you want to answer that question?
Yeah, what would disqualify a patient from a pre-pec? So I think what you'll find is that there's no sort of absolute definitive answer. I think even just a few months ago or a couple of years ago, some people would say that the quality of the skin is an issue for a pre-pec, but the reality is I don't necessarily think that that's true. I don't think Dr. Tenenbaum thinks that's true either. The truth is if there's a problem with the skin from a mastectomy, whether the...
and what he means by that is sometimes mastectomy skin flaps can be, or the tissue can be really thin. And as plastic surgeons, we then worry a lot about the blood supply and whether or not it'll heal.
Yeah.
That's what he means by that quality.
So if the quality is not great, and exactly, there's a wound problem, and or some of the skin dies, or some of the incision opens up. Whether the implant is below the muscle or above the muscle, the reality is it's still a problem. It's still a problem for infection, and it does require that we do something, often removing the tissue expander or implant. So the reality is, whether it's above or below the muscle, it's not going to really, it's not like putting it below the muscle is necessarily protective. So that would be one thing. I would say that there may be certain situations, perhaps, where somebody really doesn't want rippling, or perhaps they want a particular slope, kind of a reconstruction to their breast, or perhaps there are previous numerous scars to the skin where somebody's still trying to do an implant reconstruction. I could see a situation there where somebody may want to try a post-pectoral reconstruction. Although the reality is, I think for most patients these days, pre-pectoral reconstruction is becoming more and more common.
Yeah, I would agree. And I think that it really depends on the preference of your plastic surgeon as well. And a lot of great cooks or great chefs get great results with different recipes. And so by no means are we trying to suggest that our way is the only way or the best way. But I think in our hands, I think we both have really transitioned to quite a few of these and feel that there's very few patients that I will say you're not a candidate. In fact, more and more I'm saying I think you are a candidate. And I just am finding that my patients like it better and I like it better. And so I would say that as a woman, it's certainly what I would choose. If I were in that situation, I would definitely choose a pre-pec implant reconstruction. I think that a lot of women do really well with that. And I wanted to bring up, I bet Terry even has like a copy of it on his iPad, but there was a recent study which I was happy to see. And just like any study, it does have some flaws in it, but it did show that for women who need post-mastectomy radiation, which is something that we as plastic surgeons just hate to hear, especially with implant reconstruction, we always think about higher complication rates and more issues with implant-based reconstruction and radiation. There was a recent paper that was published in an oncology journal that showed that in women who have a pre-pec with ADM reconstruction, that potentially it may have been a little bit more resistant to those radiation changes. And so when we think about the firmness of the breast, or what we call capsular contracture, we know that firmness goes up with radiation. We don't actually think it's the same process as capsular contracture, but that's sort of for a different day. But we do know that the radiation makes that breast firmer and tighter, sometimes migrates more superior, sometimes more uncomfortable. And we grade that firmness on a scale. And what this paper showed was that in women who get radiated, that the pre-pec side, the pre-pec reconstruction seemed to withstand that tightening and that fibrosis better than post-pec or behind the muscle. And so perhaps that may be one more added benefit, that in a woman who may require post-mastectomy radiation, that the pre-pec reconstruction with the ADM may be a bit more protective.
Yeah, we think probably what's happening is that the muscle is now above the implant and post-pec and below at pre-pec. And so the radiation can tighten up that muscle and cause fibrosis of the muscle. So probably the big difference is you're not contending with a tightened up muscle if you do a pre-pec reconstruction and then need radiation therapy. So I think that's important. The other thing to note, though, is that nationally, still less than 50% of these implant reconstructions actually are pre-pec. Post-pec is still the majority of the reconstructions nationally, probably like around 55, 60%, and probably 40, 45% PrePEC, and there's other factors that go along with it. One thing that doesn't come up much when we talk to patients, because it doesn't really matter, we're doing what we can that's the best for the patients, but the ADM that we use is extremely expensive. And so some hospitals don't actually necessarily want to buy or purchase or pay for, or insurance companies, that amount of ADM. So one of the limiting factors is actually an economics one. At Barnes Hospital, we haven't really come across that problem, so we've been able to use it more, but it's also another consideration, a practical one with us.
Yeah, and just like a lot of things in medicine, with cost, hopefully that over time things become more efficient. And I think that cost in medicine is super complicated. Dr. Myckatyn has done some studies on this as well. And so, for example, that cost of the ADM may be quite expensive, but perhaps we're saving time in the operating room, which is also expensive. Perhaps we're lowering complication rates, which is also less expensive. Perhaps we're limiting the number of revisionary procedures somebody may need, which is less expensive. And so it's very complicated, but he's correct that it is expensive up front.
And what's a happy patient worth financially? Right?
I know, right?
we think it's valuable.
It's worth a lot.
Yeah, that's right. Priceless.
Priceless. That's what they say.
But you have to ask your insurance company if they feel that's the same way.
I don't think we've gotten any pushback.
No, we haven't. Not much. Yeah.
We're doing fine.
Yeah.
Okay. Any other last minute questions out there for us? No. Okay. Well, thanks for tuning in. And if you guys want to send us any suggestions for any future topics, obviously, please do that. We're happy to discuss any and all of your questions.
Oh, and also please give to the Komen Foundation. I'm doing a fundraiser for that. We'll post it on our Facebook page. So if you're interested in giving money to Komen for breast cancer research and supporting breast cancer patients, please consider that as well.
And on another note, with October being Breast Cancer Awareness Month, please, 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 I beg of you to be really mindful and respectful of this month as what it really should be, which is exactly what he just said. Put your money where your mouth is, buy products and fund research that actually is going to help with either the quality of breast cancer patients' lives or prevention. It's not just about wearing a pink tutu and wearing pink socks and wearing your pink lipstick. And, you know, I'm a bit, honestly, to be totally honest, I'm a bit sick of the pink. I want to see people put their money where their mouth is and make a real difference. And so support breast cancer research, support research and organizations that help improve quality of life for women and their family members with breast cancer. That's my little soapbox.
Well done. All right, thanks everyone.
But I do like pink.
Afternoon.
You know,
yeah.
I do like pink. You can wear.
Okay. I'll limit my pink.
Bye, guys.